aus einer national ein bisschen anderen Perspektive hier einen sicherlich ganz hervorragenden Überblick geben. Professor Cuzick, it's a pleasure to have you here. We look forward to hearing your talk. Welcome in Munich.
Thank you very much. It's a pleasure to be here and to join your group. I'm going to give you a little bit of an update, primarily on the trials, but also focusing a little bit on a few points which Thomas has actually brought up in terms of the whole issue of prevention. We like to call this, we've had some discussion, the word chemoprevention is a word that's actually, at least in English, causes a lot of confusion, and I think has maybe not been helpful to the field because it's so much tied to chemotherapy. And in fact, when the first tamoxifen trials were being run in the United States, there was a confusion between Taxol and Tamoxifen, indicating that there was all of these concerns about side effects. And possibly preventive therapy is a better term in terms of just talking about aspects that are going to be related to prevention. So again, just picking up a little bit on some of the points that Thomas made, I won't say much about this, but worldwide now, breast cancer is the dominant cancer in women. The incidence dominates that of any other cancer. 1.4 million cases estimated now, and it's increasing. And the increase is really quite dramatic. Again, this is looking at just trends. You can see that breast cancer worldwide is continuing to increase while other cancers are actually decreasing or fairly stable. So it truly is the cancer epidemic of our century, and we really have a challenge not only to try to treat more of it, but try to prevent some of it so it's actually not consuming so much resource. Well, again, I'm not going to say anything about all the different approaches to prevention. Thomas mentioned those, but of course, they need to be kept in context that for many women, the general population, control of weight, a bit more exercise, being careful about use of HRT, and a few other reproductive factors are important. But I want to focus here on preventive therapy for the high-risk women. And there really are two aspects of this that go completely hand in hand, and I think it's really important that we don't lose sight of the fact that we need to make progress in both of these if we're going to take the field forward. One is better identification of high-risk women, because the preventive therapies that we have now are likely to carry, the ones we have now do carry some toxicity, and it's important to focus our efforts on women who are at sufficiently increased risk of breast cancer that any side effects are actually worth considering. And then secondly, which of course will be the focus of this talk, is can we develop effective non-toxic prophylactic agents? Well, again, I won't go through this in any detail, but the risk factors of breast cancer fit into four simple groups. There are various things related to genetics and family history, a whole range of reproductive and hormonal factors. Women with certain types of benign disease, I think we don't do enough for women that are diagnosed with atypical hyperplasia, simply told it's a benign disease in the UK and not even increased screening. But in fact, these women have a very high risk of breast cancer and is the one group that is most susceptible or most responsive to tamoxifen treatment. So we probably ought to be thinking about one of the first areas where we could be increasing our preventive activity is women with high-risk benign disease, atypical hyperplasia, lobular carcinoma in situ. These are very good candidates for starting tamoxifen, and we should think about that more seriously. And lastly, mammographic density, which I think is ultimately going to be one of our strongest factors. Again, I won't go through this in any detail, but there are lots of genes now being identified associated with breast cancer. The two classic ones, BRCA1 and BRCA2, being carrying very high risk, but extremely rare. About 1 in 1,000 women actually have these. CHEK2 and the ataxia-telangiectasia gene are moderately more common, 0.5% roughly for each of those, and doubling of risk. But we've now developed a list that goes out to about 70 genes that have very, very small impacts on breast cancer individually. It's, 10% increase or decrease, but they're very, very common. And one of the things I think some people have suggested that this might explain all of breast cancer. Well, it certainly doesn't, but it may be helpful in terms of doing a little bit of this work. This is just a little bit of data on a cohort of 10,000 women that were actually a screening cohort that we collected in Manchester with Tony Howell and Gareth Evans, now published in Cancer Prevention Research, just getting a sense of what we can do in the terms of our ability to separate out women into high risk and low risk on currently available information. And the blue is our model. We have a model which is available on the website. If you type in IBIS or Cuzick, you'll actually find it. It's freely usable, where you can individually type in risk factors for individual women, and it will print out both the 10-year risk and the lifetime risk for that woman and for the general population, a woman of average risk. And you can see in the blue that in fact that is much better at identifying high-risk women than any of the SNPs that we have now. This is just based on 17 SNPs. But in terms of identifying women at more than 8% risk of breast cancer, we could find a couple of percent of those in the Manchester cohort, as opposed to very few just using the SNPs. And again, even in the 5 to 8%, which is roughly a doubling, tripling, 2 to 3-fold increase of risk, the classical factors are still better predictors of who are at high risk than the SNPs, although they're going to work in combination. Interestingly, the SNPs are actually much better at identifying women at low risk. We can find a few women at very low risk of breast cancer, and that's because they're sort of equally tailed. There's an effect on both sides, whereas most of the phenotypic markers we've been interested in 5 to 10% of the population at increased risk. So they're really not very helpful in terms of identifying low-risk women who might ultimately not need screening. Mammographic density, I'm not going to say very much about that, but mammographic density offers to be, I think, a really important factor for breast cancer. In our first prevention trial, we were actually able to show that we could predict who was going to respond to tamoxifen in terms of decreased risk by looking at changes in breast density. So it's a little bit, I like to think of it as the LDL cholesterol of breast cancer. Not only does dense tissue predict increased risk, and as Thomas pointed out, there's about a 5-fold risk across fatty replaced to dense breasts here, but also there's increasing indications that changes in density are early indicators of response to preventive therapy. So I think it's really a very important area. Well, now I want to focus primarily on where we are in terms of chemoprevention, looking at some of the trials. There really are 3 major classes. There are the SERMs, which we recently just published an overview on. I'll show you some of that data. There are 4 of them, the classic one, Tamoxifen, Raloxifene, and 2 more interesting, more recent ones, Lasofoxifene and Arzoxifene. Lasofoxifene shows particular interest. I'll come back to that in a little bit. The aromatase inhibitors, of course, have replaced tamoxifen by and large for postmenopausal ER-positive breast cancer treatment, and trials are ongoing to see if that will actually be true in prevention as well. And there are some other drugs that I'll just talk a little bit about at the end. The one thing that I think is important for Europe is that although both raloxifene and tamoxifen have been licensed for years in the United States and approved by FDA for prevention, there's been no such statements in Europe at all. And just this week in the United Kingdom, the NICE committee, the National Institute for Clinical Excellence, actually have come out with a recommendation that high-risk women should be offered the opportunity to have tamoxifen, or if they're postmenopausal, raloxifene. And they've basically made 2 major statements. Well, I'm going to slightly simplify them. But if your lifetime risk of breast cancer is more than 30%, which is roughly about a tripling of the basic rate, this should be actively promoted by the health profession to either take tamoxifen or raloxifene. And if it's at moderately increased risk, which is a 17% lifetime risk, which isn't very much, this should be discussed with women. Well, our initial estimates is at the moment we can probably find about 1 to 2% of the population at that very high risk population, but a substantial effect of the order to 8 to 10% that are actually in the moderately increased risk. So if one were to actually take those guidelines, it does suggest that up to 10% of the population are candidates to discuss preventive therapy, currently just with tamoxifen and raloxifene, because that's where most of the data is. But I think that's an important step forward, that we now have not a regulatory body, but in fact a body that does independently review things in the UK, hopefully this is going to be of some use to Europe, recommending that chemoprevention be offered to high-risk women. So I think this is a little bit of a sea change in terms of the fact that we now have some regulatory support. Well, just to review the trials just briefly, there are 4 main prevention trials with tamoxifen. The first was a pilot study run by Trevor Poles and the Marsden. It turned out being more than a pilot study as things got stalled. This was started in 1986 after our initial suggestion in 85 we should do such a thing. We got bogged down for about 7 years about the fact that tamoxifen caused liver cancer in rats. It was totally irrelevant, as we now know. But that held back the main trials, which didn't get started until 1992. In North America, the NSABP1 trial, an Italian trial in hysterectomized women because of the endometrial cancer concerns, and our own IBIS-1 study run mostly in the UK and Australia, but with some European inputs as well. All of those looked at the standard 20 milligrams per day for 5 years, except the Marsden study started out with a longer duration as well. There have also been a number of studies using raloxifene. Raloxifene was started out as an osteoporosis drug. The Moore study and its follow-on, the Core study, were actually for osteoporotic women. Another major study was a study called Ruth, which was aware of the fact that SERMs actually lower LDL cholesterol by about 20% in women. So it was thought that they should have a beneficial effect, just like the statins do, on cardiovascular disease. And if you could get that plus an effect on bones and maybe an effect on breast cancer, it would be an ideal drug. So Ruth looked at high-risk women of cardiovascular disease. We since found that, with the exception of maybe lasofoxifene, that in fact, for reasons which are not at all well understood, that these drugs, although they do lower cholesterol, have no impact on cardiovascular disease, which is really quite a curious and tantalizing question that needs further investigation. And then the last trial, after the initial tamoxifen data were out, recognized that an important question was to say, should it be tamoxifen or raloxifene? In the United States, the STAR trial randomized almost 20,000 women to either receive raloxifene at 60 milligrams or the standard 20 milligram dose of tamoxifen, again 5 years of treatment. Well, the STAR trial was the only direct comparison. I'll show you that first, published a few years ago now, showing that although initially the drugs seemed to be the same, with the 81-month follow-up, in fact, raloxifene was not as good as tamoxifen in preventing new breast cancers. The risk was about 25% higher. There's still a clear benefit, but it's not as effective as tamoxifen in terms of preventing breast cancer, which is an important point. In raloxifene's favor is that it does have fewer side effects. There are no endometrial problems with that at all, and it looks like thromboembolic events are also reduced on that trial. More recently, 2 other trials have been published, and again, I'll show you the overall results. Again, looking at SERMs primarily to prevent fractures in osteoporotic women. The lasofoxifene trial looked at placebo versus a low dose and a high dose in almost 8,556 women. And then more recently, in almost 10,000 women, arzoxifene has also been looked at in osteoporotic women, in which breast cancer has also been, in both of these trials, has been identified as a key endpoint, so it's been followed up front. Well, here are the results. I'm sorry that there's a lot of them on one, so we'll spend a little time with this slide. Basically, here are all the prevention trials. This is recently published overview in the Lancet just about a month ago. So here are the 4 tamoxifen trials. They all show overall there's about a 38% reduction in breast cancer incidence over 10 years with tamoxifen. The effects look to be pretty similar overall in the raloxifene trials. The early studies showed a bigger effect, which has now been diminished as we've looked at more things, and the more direct effect, the direct comparison, as I showed you earlier, actually showed that although the promise for the early studies was strong, in fact, this is not as powerful as tamoxifen in terms of preventing breast cancer. The lasofoxifene trial, again, there are 2 doses. The high dose shows dramatic effects, like an 80% reduction in breast cancer. This is also coupled with reductions in fractures and very interesting reductions in both strokes and myocardial infarctions, suggesting that lasofoxifene might be really a good drug for preventive therapy in breast cancer. Unfortunately, I think it's a Pfizer drug, and they've taken a view that they're not currently progressing this in the preventive strategy. So this is probably our most exciting SERM, at least anyway, and it's not clear how we're going to get any further evidence on it. So overall, if you look at all of these, there's a little bit of variation, particularly in maybe this big effect in lasofoxifene, but again, it was in osteoporotic patients, and we saw a big effect early with raloxifene on that. But overall, about a 40% reduction in all breast cancers with 5 years of treatment with a SERM. That effect is maintained out to about 10 years. We don't have very much post-10-year data. The effect is all in estrogen receptor positive breast cancer, where the effects are a little over 50%. In fact, about 51%, in fact. No effect on estrogen receptor negative breast cancer. In fact, slight increases, not quite significant, but approaching that. And my interpretation of that is that this is not due to the fact that tamoxifen is increasing ER negative breast cancer, but we know in the invasive setting that breast cancers eventually become resistant to tamoxifen. I think that's what's happening here. Cancers that would have appeared as ER-positive breast cancers are being held in check for a few years, but some of them break out, and when they break out, they appear as ER-negative cancers. That's a hypothesis that needs further evaluation. Also, a similar effect of about a 40% reduction, 30 to 40% reduction in DCIS. Just to put that on something that's a little bit more straightforward, if you look at all breast cancer over the 10-year period in yellow, in this high-risk population, about 6% of these women over 10 years would get breast cancer. That's about roughly double the risk. That's 6 per thousand per year. It's roughly double the risk. And with tamoxifen, we're able to reduce that down to about 4 per thousand. So about a 2% reduction. Or in fact, if you do the calculations exactly, you need to treat 44 women to prevent 1 breast cancer over 10 years. And that effect is all seen in the ER-positive cancers, where you reduce that from about 4% over 10 years to 2%. This is a curve that people aren't so used to seeing, but we think it's more important. It shows the rates at which cancers are actually occurring at various time periods. And you can see that for breast cancer, the effects are pretty constant. This is all cancers over the 10-year period. There's a little bit of an increase running, again, about 6% per year, or it's 6 per thousand actually in the active treatment period. And we reduce that during active treatment. Here, the area between the 2 yellow curves shows the benefit in the active period. And there's this continuing benefit, the so-called carryover effect, which seems to be, it's a little bit smaller, but it shows up in the following years. And that's for all cancers. If you look at ER-positive breast cancer in yellow, in blue, you see that the effect is pretty constant, this roughly 2 per thousand per year effect, which has been maintained right out to 10 years. So suggesting that, in fact, the benefits may last even longer than 10 years. And that's the current priority, I think, with the SERMs, is to see how long they're going to last. I'm going to just show this briefly. It's in the paper. We see an increase of about 70% in endometrial cancer. Those cancers, I think, are being detected much more early now because of the awareness of abnormal bleeding. There have been no excess deaths from endometrial cancer. No effect on other cancers. Again, about a 70% increase in blood clots on thromboembolic events, and no effect on other cardiac or cerebrovascular cancers or events. Nothing on MIs, nothing on strokes. It's absolutely flat. So a little bit on aromatase inhibitors briefly. The data, of course, for tamoxifen came from looking at contralateral tumors in the treatment trials. We see about a 50% increase of a reduction of AI effect over tamoxifen. If you believe, I mean, the evidence now is that tamoxifen reduces ER-positive breast cancer by about 50%, and if the AIs didn't bring it down another 50%, that's potential for a 75% reduction. In ATAC, we've got long-term follow-up. We see continuing effect on contralateral tumors right out to 10 years. The absolute benefit is twice as big, 1.7% at 9 years actually, compared to 0.8% at 5 years. So there seems to be a continuing benefit that this is going to be better than tamoxifen. The only data we have on AIs in prevention is the MAP3 trial of exemestane, which found a 65% reduction in all cancers and about a 70% reduction if you look at ER positive. Very consistent with what we would have predicted from the adjuvant studies. And the other main study is our IBIS-2 study, which has completed recruitment now. The recruitment numbers were just under 4,000. We're following them up. We've actually achieved the number of cancers we need for an analysis, and we hope to be able to present the first results of that in San Antonio this year, looking at the effect of anastrozole in a high-risk group on cancer prevention. So that's hopefully going to be available in December. A little bit on other agents. Again, both speakers have talked about them, but we've actually found now that running prevention trials are so expensive, there isn't really anybody that's prepared to fund them unless you've got a new drug. And we think that there's really interest in continuing the AI longer in women. So we want to look at women with breast cancer that have survived 5 years without a recurrence, but are at high risk of recurrence. And high risk turns out to be either node positive or a large tumor, where the recurrence rate in years 5 to 10 is still 4% per year. It's the same as in the first 5 years. So roughly half the recurrences, equal number of recurrences in the second 5 years. So these women are not cured after 5 years of an AI. We want to look at continued AI use. We want to look at metformin. Again, this is an interesting drug. And zoledronic acid. Again, the bisphosphonates, the energy reduction metformin used in diabetics, and continued AI use. And that trial is going to take about 4,500 5-year survivors, which is going to be a lot easier than a new prevention trial. So we're trying to get that funded now, and hopefully that will be up and running in a year or so. So just to finish, I think it's important that we think about a combined strategy for breast cancer prevention. We can stratify the population, identify about 10% at a 5-fold risk, another 10% at a 3-fold risk. And if we focus more of our efforts on the high-risk population, but still do things for the general population, reasonable estimates, we can talk about them in details, there is a potential for about a 1/3 reduction in incidence, but 3/4 of that's actually going to come in the top 20% if we focus our efforts on high-risk population. So thank you very much for your attention. The last thing I should say is that there are still very strong unmet needs in cancer prevention, breast cancer prevention. We have nothing yet that really we know works for hormone receptor negative tumors. The bisphosphonates might work, and we have very little for premenopausal women except tamoxifen. So thank you.